Welcome to the Animal Heartbeat. This is the world's greatest and only podcast dedicated to veterinary cardiology. I am Kieran Bourget.
And I'm Jose Novomatos. Hi, everyone. We have today with us Dr. Brianna Potter. Dr. Potter is an ACVM board-certified cardiologist and an ACVM fellow in interventional cardiology and currently an assistant professor in cardiology at Colorado State University. Brianna, alongside the team at Colorado State University, have been a pioneer in interventional echocardiography and most recently developing the TEER procedure. We'll be talking today about transoesophageal echocardiography in clinical practice. Brianna, thank you very much for joining us today.
Thank you so much for having me.
Thanks for joining us, Bri. It's fantastic to have you here. I think it'd be really good to just start with an impression of when you might reach for a transoesophageal echo in your clinic. Is it just for interventional surgery, or do you ever use it as a diagnostic tool?
Yeah, I think that's a great question. I'd say most of our utility is procedurally. So either assessing a candidate for the procedure kind of right before the procedure starts, assessing results. But there are some unique cases where especially pairing TEE with CT as a diagnostic tool, I think that has had some utility. So with most interventional procedures that we're able to, given patient size and any comorbidities, we do try to use TEE. I think some unique aspects that we might use it is, for example, we do congenital open heart here at our center. So if it's a case where, maybe there's MR in a young dog, is this mitral valve dysplasia or is this more functional MR with low systolic function? So we might do a CT and throw the TEE probe in to just get more information. So that's been really helpful.
Sometimes we wonder with endocarditis cases, as endocarditis in people that are suspect of endocarditic lesions and they are not clear on thoracic echo, they undergo TOE. And some of these dogs may require GA for other purposes. So we wonder at times if we should TOE these dogs to look for potential endocarditic lesions. Do you ever do that in patients suspected of endocarditis?
It's a great point. I think those for me are some of the most challenging consults that we'll get in the hospital. We have done it. I would not say that we do it routinely. And I think it honestly would have a lot of value because I think you see that middle-aged older dog with thickening of the mitral valve. Is that more convincing for endocarditis? And similar to what you just mentioned, I know that they do that in human medicine a lot. If there is any reason that the patient is going under anesthesia for another reason, CT, medicine workup, something like that, we definitely have just to get more information. Also, interestingly, we saw this dog with a large LV thrombus that was going under for CT because he had like large pedunculated thrombus in the left ventricle, and that dog was going under for something else. So we did put the TEE probe just to get a little bit more information on the origin. And so that was interesting. So I think, like you said, if there's any other reason that they're under anesthesia, we absolutely will. But we haven't put a patient under anesthesia just for the TEE and endocarditis. But I think it would have a lot of value, especially with 3D modalities and things like that.
And just sort of thinking about human medicine as well, it's often anaesthetists that use the transoesophageal echo, isn't it, in humans when they're monitoring output or making assessments of fluid responsiveness, things like that. Is it something that you would ever think about alongside your critical care colleagues or alongside anaesthetists to make those kind of non-cardiac assessments, but really looking at the cardiovascular system rather than the heart itself?
Our anesthesia service, wonderful here. They really, it's mostly been in the settings of intervention when we have the TEE probe in, but they've definitely partnered with us on, what do you think the volume status? What do you think systolic function subjectively looks like? So they're getting more savvy on what they're looking at and partnering with us. I would say, or post open heart, we'll have the probe in to evaluate volumes and things. But that is a aspect we haven't explored as much as in the kind of non-cardiac patient using TE for volume. I
Right.
think it's a really interesting avenue that could be explored.
What I'm so jealous about human medicine in this case that they only need to mildly sedate their patients because the images
Yeah.
are so amazing. It would be so cool if we could just go ahead because we were visiting the other day the human hospital here, and they just went like, transthoracic window is not very good. They just gave a bit of whatever fentanyl, and then they
Bedazzler
just
makes
went,
you forget, right?
exactly. And then it would be so nice if we could just, yeah, that's fine. We just TE them all, isn't it? Because yeah, the images are so cool. Um, Brianna, many of our listeners would not have done transophageal echoes. Could you maybe give us like general tips and on from someone that wants to start transophageal echo, just general tips you would tell someone that is just starting with this technique?
Yeah, I think, if there's anyone that is around to kind of show you a few tips before you start, I think that could be helpful. But I think, if you're able to get your hands on a transesophageal echo probe, I think finding a patient that isn't too small to start, I think would be helpful. And then I think some just general tips are just kind of safety for the patient, kind of probe maintenance. So in terms of entering the probe into the mouth, I think I always partner with our anesthesia team to make sure, I'm watching the endotracheal tube very carefully. We do use a mouth guard that comes with the TE probe before entering it into the patient. We use a lot of ultrasound gel, so really the same that we use for thoracic echo. So we'll put a lot of lubrication. You also can, just to get an idea of how far you need to advance the probe, kind of hold the probe over the patient to get an idea of the marker line for how far you need to insert it in. And then very carefully with the endotracheal tube, kind of inserting it into the mouth. I kind of protect it with my hand over the teeth and then into the mouth. And then very carefully, I think it can, you can also get some resistance as you're inserting it into the esophagus, depending on the positioning of the neck. I think a lot of times there'll be resistance at the thoracic inlet. So if there's any resistance there, a little bit of retroflexion. So I think that's one thing I should have mentioned too, even before inserting the probe, getting an idea of, lateral movements, retroflexion, anteflexion, kind of how it's going to move with your manipulations on the wheel. And then some retroflexion over kind of the thoracic inlet can be helpful. And then also, if it's a huge heart, sometimes retroflexion over kind of the base of the heart. For us also, especially this has come into play in TEER, but if you're needing to kind of retroflex that probe to get the right view, we got this tip from Claudio Busadori, but he uses
we do the same.
sometimes
we call it the Busadori finger.
I love it. Yeah. We're fans of the Busadori finger. So you kind of cut a little finger off of a exam glove, and then put it over the probe with it filled with gel. And then we gel on top of that and put a tight rubber band onto the probe. Terrified me at first that was going to come off in the stomach, but thankfully it has not yet. That can help just with extra lubrication on the probe to maintain that. And then I think just as much careful manipulation you can make of the probe is going to be safer for the patient. We do use kind of the lever lock to, once you get into the position you would like, kind of locking the probe there. I think, having said that, if you lose your image and you need to make larger manipulations to find your image again, I probably would unlock. But that locking, once you get into the right spot, can be helpful to hold it there. I know there can be some kind of warnings in the literature. Is that going to just create kind of more harm of the esophagus? But thankfully, we haven't seen that. Obviously, watching the temperature as you are performing the TEE study. Thankfully, we haven't seen this too much where we're seeing overheating of the probe. I think just anecdotally, if the patient's body temperature is higher or it's a large dog, sometimes we can see that. But definitely just we're always watching that and pausing it to give it time to cool down. But I feel like we've been pretty lucky with avoiding complications.
You
Yeah,
mentioned patient size a couple of times. What's the smallest patient that you would place a TOE probe in? And obviously, when we're talking about TOE probes, we have the pediatric and we have the adult sizes. So do you have any kind of rules of thumb about how to select for patient size and probe size?
I'd say 3 kilograms is probably a rough cutoff of when we feel okay still using the adult probe, although it's funny looking at the human literature on that's probably pretty small for them. But we have had, thankfully, no complications with using the adult probe down to 3 kilograms. We just got the Philips X11 probe, the pediatric probe. So that has expanded our utility of TEE in the smaller patients or in
Right.
cats, which has been fun. But we did do a 2.7 kilogram tier a few years ago with the adult probe. But I think that was stretching the utility of it. So that's our rough cutoff.
Some of the initial pediatric probes, they have 3D options, right? And they would only retroflex and antflex and not have lateral movements. The most recent, like the X11 you mentioned, Philips has 3D, and you can also move it laterally. Is that right?
Yeah, it has all the capabilities of the adult probe and 3D. I get the sense the 3D is like in some mitral valve evals and things is maybe not as good as the X8 probe, but it is, even with, it's been so nice to use in like cats to evaluate. Even our surgeon likes to use it for like PDA ligations to make sure there's no residual flow, or we did use it in like a PA band, which was fun to look at the VSD flow.
Nice.
So the pediatric probe has been really nice for the smaller patients.
I think cats, for me, have been a challenge in the past to try and pass a standard 2D adult transesophageal probe. I just think it's big, and cats find that hard. So it's nice to be able to open up that avenue, isn't it?
Mm-hmm. I was just gonna say small dogs doing like AVP2s and things when you're doing like a transvenous approach.
Right.
That has also been pretty nice just to assess stability of the device, residual flow, things like that.
And in terms of aftercare, for you perform your TOE, do you just kind of wipe it down, alcohol-free wipes, give it a clean, or is it sterilized like an endoscope might be sterilized?
We've been looking into this over the last few years on what solution is best. We have found a kind of enzyme cleaner. It's called Miltex EasyZyme all-purpose enzyme cleaner. I'm sure there's a lot out there, but
we'll get them in to sponsor the podcast.
Yeah, you should. Yes, so we've used that. We've kind of filled our sink in the clinic and put that solution in there and let it soak for about 20 to 30 minutes. So that's been our approach. I'm sure there's other good solutions out there for medical equipment. But yeah, it's been, even if we're using it for one and jumping to the other, we try to let it soak for a good amount of time.
So in terms of interventional work with the TOE, is there a procedure, sorry, TOE, I'm so British, the transesophageal echo, however you want to spell that. Is there an intervention that you wouldn't place the transesophageal because you thought it doesn't add any value for me? Or do you think it consistently adds value on top of fluoroscopy angiography?
Honestly, I would say, I mean, if we did like an intrahepatic shunt, it's less cardiac related, but that I know it's reported that people have used that. We haven't used that as much. I think honestly for the cardiac interventions, we've found utility in a lot of the procedures, even if it's, putting the TE probe to gain a little bit of experience looking at other things as the intervention is going on and maybe adding a small amount of value. Even things like CTD that you could argue, is pretty good, just guiding with fluoroscopy and invasive pressures. Even that we've found some utility, kind of looking at they'll flow across it. So yeah, I think even if it's maybe not going to change your plan, I think for us, we have a big team and everyone wants to kind of get experience on the TEE probe. So even if maybe it's not going to change our interventional route, I think if people can put the probe in and start looking at the mitral valve or looking at the pulmonary valve for future interventions, we've found utility in that too.
And I guess just that additional layer of confidence. Yeah, okay, I know I'm in the right place. When you haven't got contrast in the angio, okay, yeah, my occlusive device or whatever we're doing is in the right place. That layer of confidence, I guess, can just reduce your complications, maybe, even if it's that 1 in 200, it might help to avoid. Then I think that's a benefit, isn't it?
Yeah, absolutely. Even in pulmonary valve stenosis, where, in the beginning of my training, we were not using it as routinely. I think now I use that as such a integral piece of, am I going to keep ballooning? Do I see a dissection? I mean, that has really added that real-time value on, what are the leaflet excursion? What does it look like? What's the flow across look like on spectral Doppler? So things that we didn't even know could, factor into our decision making in the beginning, I think has added such a value. And yeah, especially in PDAs, I think, a lot of our residents may go out and not have a huge team to
Right.
have an extra person to perform TEE. So, even in those cases, sometimes we try to ask them, okay, if you didn't have this, what decision would you make in this moment? But it is pretty nice to just have that extra layer of confidence.
It feels so hard if you would need to do a PDA now without TOEs or
Yeah.
without TEs, because sometimes we still do angios on our PDAs, kind of more a protocol thing, and
Yeah, we did too.
and then
Same.
then when you try to, we think, oh, you're going to need to measure, and you can only rely on your angio to decide device size. It's just, yeah, it will be way, yeah. Certainly it was done many times. There's certainly many people doing it, but it will be way more challenging. Can I just ask you, as we were talking about complications and so on, and as you said in this report, the complications are rare, which is great. And something I wanted to ask you is, as we all see more and more brachycephalic dogs, especially for dogs for pulmonary valvuloplasty and so on, do you have any extra caution care with brachycephalic dogs, especially to avoid them to aspirate and vomiting and regurgitate after TOEs? And any tips, anything you might do differently?
Yeah, no, that's a great point that I wanted to touch on too. I don't have any magic solution, but we do worry about them more with TEE. Probably with anesthesia in general. A lot of our PS, like pulmonary stenosis cases that we're planning a stent or a balloon on, will do a cardiac gated CT like 1 to 2 days before. And some of those patients will always give Serenia the night before, like to go home with the owner. And then, yes, our anesthesia service is very diligent to kind of watch for regurgitation during any anesthetic event. We have, just with CT and not just the anesthetic event alone, without the TEE, we've seen commonly regurgitation. And so now we're kind of trying to be a little bit more proactive, even once they go under anesthesia in the post-op period. Some of them, if we're really worried, like metoclopramide, pantoprazole, kind of hitting them with a lot of GI meds. And then what's been unfortunate in some cases is maybe for the CT, they've had regurgitation post-op, and then we need to do the procedure, 2 days later. And so I remember one case offhand that we just, there was so much regurgitation in that kind of 1 to 2 days to get her back on track that we didn't do TEE for the procedure. It was okay. We did a balloon and it all went well, but I think those are cases where it can be more challenging if they're already having GI signs before doing it. So in those cases, we'd be more careful, but really as proactive as you can be with kind of GI meds. They're frustrating cases because no matter how careful you are, it just feels like it's unpredictable which ones are going to be so reactive to it.
something that you mentioned briefly, which is, so I think something that is really cool is kind of this new area in veterinary cardiology, I think, of interventional echocardiography and interventional echocardiographer. Because when we in the past used TE for PDAs or balloon valvuloplasties, maybe we would just acquire the images and maybe ask an intern or an anesthetist just to keep the image
Yeah,
still and for
just
us to
keep it up
monitor.
there.
Yeah, exactly.
Yeah.
And exactly, just keep it there, don't move. But now there's certainly, and that's in my regard, is what I think really exciting about TEER is not only the procedure itself, is the amount of different stuff that is developing alongside TEER. And certainly TE is really exciting how fast TE is growing, right? To assess before the procedure and guide the procedure and so on. But what I'm trying to ask you is, because now there is this approach that you would do a pre-op assessment, which certainly we would never do before a PDA or a PS and so on. So if we now discuss a bit here, can you tell us why is it important to do a pre-op T assessment? And what else can T give you that transthoracic echo is not giving you? Or is T better than transthoracic echo to assess if a patient is a candidate for a TEER procedure?
Yeah, I think it has really been game changing for us, just to assess. I think, we do our best to assess the mitral valve on transthoracic, but I think this is such a new avenue in that, we really never needed to know the exact, segmental anatomy of the posterior leaflet or, where exactly the jet regurgitation is originating or, the exact length of a leaflet. I think, those are all now new things that we need to be more aware of, and it definitely is in our decision making. It's very vital. So I think, yeah, it's a great point, and I think we kind of have two approaches here now with TEER, where there are some patients where we'll look at the transthoracic study that's sent by a referring cardiologist, and let's say it looks a little bit like there may be some risks just based on transthoracic, or there's still some questions on maybe that regurgitant orifice doesn't look exactly centrally at A2P2. Some of those patients and owners will actually be willing to come to us, as just an evaluation visit. So we'll just do our transthoracic study, and then we'll anesthetize them just for the TEE. And that has just been also nice for some owners that want a little bit more time to decide on whether they want to proceed with TEER. We can give them that information, that detailed information, short anesthetic event, wake them up. Since we get a lot of referrals that are out of state, some owners can't come for 2 visits. So we definitely, probably the majority of our TEER cases will still do that morning of. But we very often will do that kind of in the prep room because, as you know, things can be very surprising on the transoesophageal. You can see something that you didn't expect to see or that changes your idea of their candidacy. And so that way we're not, fully shaving the patient, prepping them, and rolling them into the OR. So yeah, I think there's just so many aspects that you can see, aspects of candidacy that you can evaluate on TEE that you can't evaluate on transthoracic. So I truly think it has been game changing for us.
Have you got any examples of a big red flag that would either make you change that individualized risk assessment, that conversation with the owner, or make you say, this is unsuitable. This is a hard no, because we're going to either have a really unstable clamp on the valve, or we're going to potentially damage the valve. And what is there you would see on transoesophageal that you're not going to see on transthoracic echo?
I think there's kind of 2 ways to think about candidacy. So definitely factors that are making me think that this candidate is more favorable versus unfavorable. I think some aspects that for me are more unfavorable. I think a big red flag is a posterior flail. So right where you're trying to clamp, if there's a part of the P2 that is flailing, that's going to be posterior leaflet is already kind of the more risky, aspect
it's
to
shorter,
the
isn't
landing
it?
zone.
Thinner.
Yeah. So if that's flailing, I think for me, that's an absolute kind of no-go. I think in terms of, there are some aspects of the anterior leaflet that make me a little bit more worried. So I have had we've had some cases that have been more risky where the anterior leaflet has a super high prolapse height. So we've kind of called that billowing, or kind of from the human side, more like Barlow's like, um, a more Barlow's like valve, where honestly, from like the hinge point to the leaflet tip, it's just prolapsing the whole length of it. I think that can be a worse landing zone for the clamp. Um, so I've been more nervous about that. And then I think really if the AP dimension, the anterior posterior dimension, is too large or too small. So for me, kind of the range for us is now kind of 14 to 22 millimeters is the range that we have device sizes available. And if it's too big, I think you just set yourself up for not being able to adequately grasp those leaflets. And sometimes I think the posterior leaflet can surprise you on transesophageal, where you didn't see that on transthoracic. So if there's, maybe there is a flail component that you couldn't really appreciate, because I think a lot of our views are looking more, especially like a 4-chamber view is looking more at P1. So maybe
Yeah,
that looks
yeah.
fine. But, if you're not getting the right view to look at P2, or there's really not a great view to look at P3. So, if the posterior anatomy is, if there's flail somewhere you didn't expect it. And then one thing that I think has been interesting is we never had a great way to evaluate kind of how wide is P2, what is that, what do those indentations and folds look like in that posterior leaflet on transthoracic. So I think, if there's an extremely narrow P2 segment that has quite a bit of prolapse, that might be a pretty risky landing zone that doesn't give you a great room for error, with any rotation or any, movement off of that central area.
I just think it's super hard to get the resolution on the TTE, even in a dog that we'd say, oh yeah, they're a good dog to scan. They give you good images. I just don't think the 4D probes for transthoracic are good enough for resolution for providing those images. Certainly when you compare the 4D transthoracic versus the 4D transesophageal, the transesophageal is like a different world in terms of the resolution. And I think that's just vital for these sort of procedures, isn't it?
Oh, absolutely. I think, I encourage kind of our residents to be obtaining those transthoracic images, 3D and
Sure.
4D images. I think, I kind of use it in a comprehensive review with the other 2D images you get, but you can't hang your hat on that view, because I think the resolution is just never quite what it is. And especially with the posterior leaflet, I think it's just
Yeah.
really hard to see. So I agree with you.
As many of our listeners will be mainly doing transthoracic echo, and even though this is a TE podcast, could you just remind everyone what would be like on transthoracic echo a perfect candidate for TEER versus an unfavorable candidate? So a case where vets, cardiologists could consider referring to a TEER center versus a case that is an absolute no. Then we can discuss the gray zone ones. But could you just summarize to us what is like the perfect favorable case versus an unfavorable case?
For me, when I'm thinking even on transthoracic, is kind of 3 components of candidacy. Like I talk to owners about severity, their anatomy, and then the AP dimension for device sizing. So I think starting with severity, I think, big picture, is this patient going to be severe enough to warrant referral? So most of the patients that we're accepting as candidates are kind of in that more advanced stage B2 and early stage C. I think the more advanced stage Cs and Ds, I think just we aren't able to get as much of a reduction in those patients, and they're probably a little bit more risky in terms of anatomy. Within kind of that more advanced B2, we've kind of used more of a comprehensive evaluation to assess whether they're advanced. So, LAAO and the LV dimension and diastole normalized both around like 2 or greater, E-wave velocity greater than 1. And then if you're able to assess regurgitant fraction, using that kind of as a greater than 50% regurgitant fraction. So using those all comprehensively together for severity. In terms of kind of anatomy, I think really evaluating, what does the prolapse or flail of those leaflets look like? So, if we talk about it's for us, we've just kind of used the idea behind like a vertical coaptation gap or more horizontal. So if there's prolapse of that leaflet tip, but you kind of imagine that, if you kind of brought that tip back down to the annular level, the leaflets would touch. That's more of a vertical gap. That I think is more favorable than having a horizontal gap where you have just massive annular dilation. And because now I'm thinking if I'm trying to grasp those leaflets and bring them together, that's going to be harder. So looking at kind of the flail or prolapse of the anterior leaflet, we have done anterior flail leaflets before. I think what's more favorable is probably the ones that maybe just the tip of the anterior leaflet is flailing versus, is it flailing like all the way from the hinge point? I think that is more risky. So I think those are some anatomic characteristics. Also just getting multiple views of the mitral valve. So 4-chamber, 5-chamber, and then what maybe hasn't been as useful before, but I do like looking at the mitral valve on short axis on transthoracic. So, looking at the characteristics of the valve, sometimes you can see little chordal flail that's indicating where the flail segment may be on short axis, or putting color on it to really see where the flow convergence, kind of where that vena contracta may start. I think that can be very helpful, which referring cardiologists can do. And then most vital on a transthoracic study is on the left apical view, getting that 5-chamber view optimized. And that's where you're going to measure from the hinge points during systole in that early ST segment, measuring the anterior posterior dimension. That gets you an idea of, is this even within the device sizing range? And so, for us, around 14 to 22 millimeters, and just rough idea for body size, because that could kind of be maybe a first indication for a referring cardiologist. But usually kind of once you're getting greater than 14 or 15 kilograms, it's kind of that balance where, yes, you could intervene earlier because the AP dimension is still within that range, but it's probably not going to be a case that's technically severe enough. And once they get severe enough, they'll probably be too big. And then for size-wise, too small. We have gone down to the 2.7 kilograms. I'd say sweet spot is probably greater than 4 kilograms, just with like being able to use the adult TEE probe and just device sizing with severity. But I know other operators have definitely kind of pushed those limits around the world to get smaller and smaller.
And if we just step back a bit, and if you could guide us and our listeners through your, let's say, protocol. So when you start, even already intra-op, and you're assessing a patient for TEER, which are your 2, 3 to-go views? What's your protocol? Which views do you start with? Which measurements do you do in each view? And maybe also interesting to tell us, what should people be careful about to avoid foreshortening the LV, for example? Those kind of things.
Yeah, that's a great place to start. So I think when entering the probe into the esophagus, really you're going to see a nice kind of view of the mitral valve at that mid-esophageal view. So thankfully, that is a pretty nice spot to get to. Doesn't take that much manipulation of the probe. So just entering it in, mid-esophageal view. And then really the first thing we're looking for is this commissural view. So what that is really kind of seeing the mitral valve as well as you can, with as elongated of a ventricle as you can. So sometimes that's kind of advancing the probe in, retracting it. And then this commissural view, kind of what we're looking for on that view is using the seek angle, usually to about 20 to 40 degrees, where you're seeing, and this can be a little challenging to find, but kind of where you're seeing this floating segment of A2 right in the center, and then you're seeing really defined posterior leaflet on either side that are shorter segments. So you're seeing kind of P1 that's laterally, A2 that's floating in the middle, and then P3 that is medial in kind of these small defined segments. So when you think that you have, and I think one thing is ideally, you're seeing these two papillary muscles. I think depending on the patient, they may not be perfectly symmetric. So not necessarily going on just the papillary muscles, but really looking at that leaflet themselves. And then once you think you're in a good kind of commissural, and I sometimes will like go from 0 to 50 multiple times to see where we think we should land. I think one nice check is you can put kind of the biplane, whatever for your system it's called, for us X-plane, but the biplane cursor right over P2, and then the resultant view should be really that inflow-outflow view of kind of seeing, and that'll be right at your kind of A2, P2 segments. You should see the aorta. I think for us, it has been a balance where sometimes we're not seeing, a perfectly optimized aorta. We're really focusing on, we do want to see the aorta, but we want to see that kind of that commissural view is nice, and that we can see some aorta and we see that A2, P2 segment. I think what we've used sometimes to kind of check our work is using like an MPR feature, multi-view for Phillips, but really using multi-view to look at exactly where that cursor is going to be across the A2, P2 segments on the 3D. Make sure on 2D, that's where you're making these vital measurements. And then for those vital measurements, it really is kind of that AP dimension right across that anterior posterior dimension. And then we look at it in systole. So kind of right at that early ST segment, right at the hinge points. And sometimes it is like watching the valves opening and closing, really being sure of that hinge point, which I think can be challenging on the posterior leaflet, especially. And then leaflet lengths, your kind of pre-op leaflet lengths. We do that kind of in diastole when they're straight, kind of finding an image where they're nice and straight and using a straight feature for those. So yes, getting that commissural, your inflow-outflow view is on biplane, and then, getting a nice optimal 3D image from that plane. And then those are really kind of the main three views that we're looking at, with kind of sprinkling some MPR as needed. Like, for example, a few months ago, we did one with a sternal abnormality, and it's the heart was just shifted in the chest. So we were quite unsure about our measurements. So we used MPR to be more sure. And then tips for foreshortening, we kind of learned this after, some experience with TEER, where we really found that the optimal way to find even your access site is going to be if your both images are very elongated and straight up and down. So what we found there is that if your probe is too far in, your commissural view may look fine, but then when you go to X-plane, your inflow-outflow view is going to be quite tipped. And so it's just not a great way. You'll see when the surgeons are kind of pushing on the apex, you'll see it in one view, but not the other. And that's our indication that we're probably not in the optimal viewing window. So that's where we have kind of retracted the probe in the esophagus and then retroflexion, just to kind of, and fluoro can help you with this. So you can kind of see where your echo probe, how is that looking kind of down the apex of the ventricle. And so I'd say that was a big learning tip when we were lost and we couldn't see on both views where the surgeon was pushing with kind of a cotton tipped applicator to see where the access site was. We're probably foreshortening. So that's where the kind of Busadori finger has helped sometimes, because if you retroflex and you're losing contact, that balloon with gel in it has helped. And then I would say just anecdotally, the dogs with kind of they're still having large left atria, but the smaller left atria have been harder to kind of keep good contact with getting a good view. So that's where I would say the dogs with the bigger atria are better to maintain contact with that retroflexion.
Interesting. I'm glad the Busadori finger term is catching on. I think let's share it widely and see how
Be
Claudio feels.
famous.
Yeah, well, more famous. He's already got the book, the podcast, and now this.
It's a famous guy, yeah.
So we're talking about interventional echocardiography. So not just diagnostics and candidacy, but decision making intra-procedure or intra-operatively. What are the big decision points for you if you're running the transesophageal, I nearly said TOE again then, during a TEER surgery? What are your critical decision points, and how can you be swayed for, yeah, this is going to be a good result, let's hold, let's release, or no, we're not happy with this, let's reposition, let's reassess?
This has been a big learning curve for us too, because I think as operators out there probably know, it's not benign to be grasping the leaflets and kind of letting go and reclamping. I think some decision making. So I think for one is kind of placement. So if a grasp happens and let's say it's rotated or it is not on A2P2, or you're worried, this is now grasping in an indentation in the posterior leaflet. I think just like the first visual of, are you clamping where your target zone was? That can be maybe an indication to regrasp. I think also just, measuring the leaflet lengths, and that's one huge red flag, Kieran, that I didn't mention before, is if the posterior leaflet is less than 6 millimeters, I'm more worried that you may not have a good landing zone. So looking at leaflet grasp, ideally you're getting, in a perfect world, like 6 millimeters grasp on each of the anterior and posterior leaflets. So, was it aired too much posterior or too much anterior where you don't have enough of one or the other? I think that could be where you would open up the clamp. And then for us, we do just look at the 3D image right before release. And I think what we've learned is if you're seeing P2, the posterior leaflet, really prolapsing out of the clamp, I think that has just for us been more of a red flag on, do you have a good enough grasp, and could you be set up for more of a single leaflet detachment if it's kind of causing tipping of the leaflet? So yeah, and then I haven't seen this as much, but we were talking to Hong Yu kind of in the beginning, they don't want to see too much squeeze in that anterior posterior dimension. So if it kind of creates, like they call it, like the gourd sign, and it's squeezed in too much, is that too much tension on the valve? I can't say that we've seen that, but in theory we look for that too. So those are, just some of the beginning things that we're looking at. Or if, I'd say lastly, if on color Doppler, like a quick glance, how we're looking very quickly is color Doppler, quick spectral Doppler to make sure there's no overt stenosis, leaflet lengths, and 3D. I think on that color Doppler eval, if the leak, let's say, looks no better, or, there's concern that there's a huge jet on one side that kind of wasn't more apparent before, maybe that's a reason to regrasp. But grasping,
you've caused an exacerbation of a fold, you mean, or a valve cleft or something?
Yeah, or it could be another indicator. You like shifted over too much and now there's just this huge, medial jet. We won't do it if we see like a huge regurgitant, or if it's near an indentation to start. I think those are rare, but yes, did you somehow distort things where it opens up kind of a large regurgitant orifice on either side? But now we'll talk about, I'm sure, double clamping. I think we do now have some, if we think it looks like a really good grasp and it's better, we do have now somewhat of a second option to further reduce that MR after. So yes, it's a balance between too many grasps but you really need a stable clamp.
Brian, if you could tell us more about your in-face view and why is that useful? And I think I remember you, because we have talked about vena contracta before in previous podcasts and
Right.
how to assess MR severity and so on. If I remember right, you have been using 3D vena contracted area. Can you tell us more about that? Why would vena contracta be important and how do you measure it?
It was actually after a few years ago, I went to ASE and I attended a workshop by Dr. Rebecca Hahn, where she actually was just showing how they're using vena contracta in setting of, let's say, like MitraClip. I came back and that's when we started using or just exploring vena contracta area more. I think it can be helpful, yes, first just to look at kind of severity. So I think what we don't know in dogs yet, that probably will need to be indexed to like a body surface area, but we don't have a great idea yet on kind of where that severity lies. But I think initially, using that to just kind of get a number. So for us, well, in a human, kind of 0.4 centimeters squared would be severe. I think we're seeing some vena contracta areas pre-op, depends on the size of the dog, but sometimes up to like 1 centimeter squared. So these dogs just have
Yeah.
such huge regurgitant orifice areas. So we get it kind of a pre. So I would say if we're getting, anything around kind of 0.3, 0.4 or greater, for us, those have kind of correlated with more severe cases integratively off transthoracic. It is a little challenging to get like regurgitant fraction on TEE. You really need kind of that aortic flow as well. So you can kind of get the VTI on the aortic valve to calculate that. I wouldn't say we're doing that as routinely in the TEE. But looking at a pre-op vena contracta area, you do need kind of a special package to do it on CART, the 3DQ for Philips. But so getting that initially, I think what it also helps with not only severity, but kind of where is the regurgitant orifice. So sometimes it kind of, I think looking at a en face with color can be overwhelming sometimes because it's just the spray of the MR up towards you into the atrium, but kind of really being able to slice down all the way to the level of the vena contracta, seeing where, are there multiple vena contracta, multiple jets, where is the largest jet? And then we are using it for kind of clinical decision making after we deploy the clamp. So it's not in moment to do any type of assessment during that vital moment while you have the clamp still on the delivery catheter. But afterwards, we've been using it, and I know they do this a lot in humans on deciding between one or two clamps. So, if ideally we reduce that regurgitant, we reduce the vena contracta area by ideally 50% or greater. So if there's still quite a big number after the clamp's in, that's when we might consider a second clamp too. But something we've been exploring, I think there's still a lot of potential in terms of kind of research in this area, but we don't use it as our only factor, but definitely more and more kind of leaning on that for procedural kind of just assessing results too.
When they're anesthetized, the cardiovascular system is under a whole heap of stresses or not, that's not present when they're unsedated. So what I'd be interested to know is, in your experience, does that reduction in the vena contracta area on transesophageal echo correlate with remodeling down the line, reverse remodeling, or reduction in diuretic requirement, or patient-based outcomes rather than echo-based outcomes?
Yeah, I think that's a great point. We're actually hoping to look at that soon, just to kind of look at, because we've been obtaining it in our patients. So like retrospectively or prospectively looking at this. I will say the point about anesthesia is so true. I think any result that we're getting still under anesthesia post, clamp deployment, I always say, it's going to look more, there's going to be more MR, I'm sure, tomorrow when they're awake again. So I don't think that reduction, I mean, sometimes we're seeing reductions of vena contracta area by 80, 90%, but then when they're awake, it's not that pronounced. So I think just keeping
Right.
that in mind, that it's not going to be a perfect kind of apples to apples assessment with the post-op echo. I do think, though, that it's giving us a better idea intra-op on what we've done. So if that clamp remains stable, and if we were able to get, let's say a 75% reduction of our vena contracta area intra-op, I think those are the ones where, long term, we are seeing more reverse remodeling. We are seeing kind of in our latest paper, we were showing that if you're able to reduce that regurgitant fraction to mild postoperatively, those are the ones that seem to, have less cardiac related outcomes. And so I think it's giving us a kind of window or an idea into the future. I don't think it's going to, be that perfect match on reduction, but I do think this is going to be really interesting to look at. Can we predict based on that vena contracta reduction how they're going to do long term if that clamp stays very stable in place?
Makes sense.
One other aspect to evaluating candidacy, I think, is really, which we haven't touched on, is because we talked about favorable and unfavorable. I think, like Kieran mentioned, I definitely have these kind of some red flags where, like, short posterior leaflet, flail posterior leaflet that weighs not to proceed. I think with another aspect of all of this is really kind of, owner's risk tolerance. So, maybe there's other factors that are less favorable, maybe multi-segment prolapse or a really wide jet that I don't think we're able to really reduce that all the way to mild. Maybe we can get some reduction, but not have an awesome result. There are some of these things where I'm still willing to proceed, but maybe it's with, I think that other factor is really the owner's kind of risk tolerance. And, do they, how old is the patient? Are they able to pursue open heart surgery? I think these are all very complex parts of candidacy. And so, when I was thinking about this podcast, I was really thinking about, there are some factors of being unfavorable that will affect clamp stability. And for those for me, that's a red flag not to proceed. But then there's probably other factors where, yes, I can get a stable clamp on there, but they're more unfavorable in terms of your result on how much you can reduce the MR. And so for me, like multi-segment prolapse, probably, although not ideal in terms of MR reduction, I probably can still put a stable clamp on or put two clamps. But so that was just one other thing that I was thinking about in terms of it really is that comprehensive discussion with the owner on, what are the risks? What were they hoping? Were they hoping to get this dog off all meds and have no MR? Then TEER is probably not the best situation or decision for them, as the dog really young and can pursue open heart. So that's just in terms of unfavorable, probably two buckets of unfavorability that I think about is like clamp stability versus reduction.
Because there's a big difference between if we define success as survival, that's one thing. But if we define success as a good reduction from severe to mild MR, that's a different question. So as you say, that I guess there's two different aspects to, I mean, we're talking about TEER, but anything, candidacy for PDA occlusion. If we have an ellipsoid orifice, in the PDA, an ostium, sorry, in the PDA, which is very mobile and, is I don't know, 10 millimeters on its long axis. Well, we're all going to feel a little concerned about an ACDO stability in that case. So I guess, can we place it and the dog will survive? Yeah, probably. Are we going to get a great result, or are we going to get residual flow? Yeah, I mean, maybe we are. So we need to think about different options. And I think it's one thing to talk about survival statistics, but it is another to talk about success for the dog. And as you say, we've got to judge it in the context of that owner and the dog's circumstances, haven't we? And I think that's the beauty of the sort of assessment prior to a procedure on transesophageal echo. You've got a really high resolution, really detailed assessment in 3D that allows you to individualize that risk benefit conversation, whether it's a TEER or whether it's something else. I guess the risk is just more nuanced with a TEER, isn't it?
Right. And I think that's, we learned early on, what seemed to be more unfavorable, risky, but I think what's been interesting, just as part of the learning curve, is now that you're seeing more and more valves, the more that you're seeing more and more, procedures and results, you can kind of almost start having that educated conversation with the owner on this. I've seen cases like this that, have responded very well versus, you can kind of start to set up expectations even before the procedure on, with this multi-segment prolapse, yes, I think we can be successful, like you said, with putting a clamp on, but in your 5-year-old Cavalier, we might not be able to reduce this to mild, and this will still be an issue, for your pet going forward. So I think that's also been part of it, is trying to predict kind of how the clamp is going to reduce that MR and just educating owners prior to going into the procedure.
But I think it also makes it, of course, challenging. In one hand, it's absolutely certainly it's absolutely fantastic that we have kind of 3 different treatment options for mitral valve disease now, right? Medical treatment, TEER, or open heart mitral valve repair, which, for example, here in London, Cambridge, around London, we have the 3 options. And so, as you're saying, it's really important to discuss with the clients the pros and cons and how much risk they want to run and so on. But it would be absolutely fantastic to have a randomized clinical trial one day, which would be really difficult to design, but just to assess at least medical and TEER would be so neat, so neat. Like 3 arms, right? Treatment, TEER, and treatment would be so nice. And as Kieran was saying, beyond survival, just to see how could we affect the natural history of the disease would be how much can you delay stage C or something like that. Would be,
if anyone listening out there wants to fund that study,
we would love
get
it.
in touch. Reach out.
It'll be hopefully it will happen.
I guess one thing in closing I wanted to just mention is all of my experience with TEE really isn't possible without our team. So I didn't want to forget that. Is just that we have a big, awesome team at CSU. And sometimes I'm in the procedure. So we have very talented residents, fellows, other faculty on TEE. So wanted to give a shout out to our whole team, because I'm definitely not the only one pioneering all the transesophageal echo.
Takes a village, doesn't it, I think?
Yes.
But that's an interesting point, Brianna. In a team like yours, and again, you guys are pioneering and pushing the boundaries on this procedure. It's interesting. What you said is interesting. So you don't have like fixed roles. You will not be one person would always do T, the other one would always do the procedure. Do you shift roles? Do everyone will do T, everyone will do the procedure? How do you organize your team?
Yeah, it's a great point. I think, all the faculty here have an interest in imaging. So I think we all try to get our hands on the probe when we're not the primary on the procedure. I'd say when we are the primary on the procedure, for example, with TEER, we are like more specific on, there are a few, like when Bernard Chi was here, he did a lot of that. Brian Scanson beginning did a lot of the pioneering of TEE. And then now we have a really talented resident, Lalita Tentisuat, who she's like our TEER guider. So when she's out, myself and Bruna Del Nero she is also getting more competent with guiding TEER, but we're more selective on like people have to have really intense TEER experience with TEE. But with all the other procedures, PDAs, PS, all the other ones, we are trying to rotate and get other residents on. So I'd say that is not as kind of strict on who does it. We do try to get a lot of hands on it, but I think TEE for TEER is so specific that it has just been a few of us that have really guided those procedures. So I think, getting your whole team up to speed, but maybe at least for now, for TEER, it just seems to be that you maybe have one person that is really specializing in that. So I think that's how we've approached it.
Yeah, totally.
Yeah, it makes a lot of sense.
Makes complete sense. Brianna, this has been fantastic, really. Thank you so much.
Thank you so much. Fascinating conversation.
It's been fun.
Brilliant. Thanks again for joining us.
Thank you, guys.
Thanks, Bree. Take care.
Bye.
See you later.
Thank you.
Bye-bye. Bye-bye. Thank you. You have been listening to The Animal Heartbeat. If you would like to reach us, email us on animalheartbeat@gmail.com.
Remember to like, follow, or subscribe wherever you get your podcasts, and check out the website animalheartbeat.com.